Welcome to Inside View. I'm your host, Joel Metzger, and joining me on the show today is Dr. Randy Smart. He's a board-certified internist who has a practice in Murphy's. Randy, welcome to the show.
Thank you, Joel. It's great to be here.
Well, I'm really pleased to have you back as part of our ongoing series about various common medical issues that really would make a difference in a lot of people's lives in Calaveras County. And so thank you for taking the time to continue with this series.
You bet.
On this show, we're going to talk about dizziness and also get into vertigo, which can be very severe and very scary for patients. And, you know, one thing I didn't realize is just how common dizziness is. So can you put that into perspective for me?
I think I can. When my practice does a lot of primary care, we do consultations too, but we do a lot of primary care. And in a practice like that, every day you have patients who are presenting with dizziness, who say, I have a problem, I'm dizzy, I'll need some help. And it is easily one of the top 10 things that you see every day. Can be very disabling, can cause people to lose work time, maybe even lose parenting time, causes a lot of anxiety. So it's very common, very disabling, and there is a lot patients can know about dizziness that they could benefit from.
So what exactly is dizziness? How would you kind of identify that?
That's exactly how we would start the appointment. We would say, well, what do you mean when you say dizzy? And it's really interesting for different patients. It means different things. We kind of categorize dizziness into four different categories, but one of those categories is just a very spinning, everything's moving kind of thing, and that is how they think of their dizziness. Another category is kind of the idea that you're about to black out, like everything is just closing in on you, and things are starting to get gray, and I'm going to go out. Another category, and a really common category, is just the idea that you can't quite get balanced. You know, you're not sick, you're able to do the things you do every day, but you just kind of feel off balance. And the real term for that is disequilibrium, but patients usually describe that as dizziness. So, and there's a few others, but that is the first question we ask is, what do you mean by dizzy? Because they are very different syndromes.
So what of those four would you say tends to be the most common?
Right, so they're all common.
All of them?
They are, but the most common of those is vertigo.
Okay, and we're going to probably touch on that a little bit later and delve into vertigo.
We should.
Okay.
Right.
Well, then let's go into the spinning. You said that was the first one that you mentioned. So if they come in, the world appears to actually be spinning like you're on a merry-go-round, or how would you describe it?
Exactly. It's a sensation of movement when you're not moving. And that actually is vertigo. And so it'll be that the ceiling is moving or the walls are moving, and you know you're not moving, but everything else is. And that is one of the kinds of dizziness. And then there is the kind where you think you're about to pass out, black out, and then that's very common, probably 20% of patients. And then there's the disequilibrium, the I just can't quite get balanced. That's another 20% of patients. So they're all, and then there is actually a fourth category that we think is more psychiatric. People with anxiety or depression can have the sensation of being dizzy. And when we really go through the testing and we really look at what we think is wrong with them, it kind of goes back to maybe some anxiety or depression. What's really interesting is something on the order, if you look at data from large medical centers, something on the order of 30% of patients who are dizzy have more than one kind of dizziness. So you don't have to have just one problem. You can have two problems.
When you feel like the world is closing in on you, maybe like a blackness is coming in or something of that nature, that almost reminds me of if I got hit in the chin really hard, I fell off my bike. I remember kind of seeing stars, and it seemed like the blackness was closing in when I was about to pass out. Is that a similar sort of effect as when they feel this dizziness, or is that a different sort of a feeling?
That's really, it's a similar feeling, but it's a different problem. The about to black out syndrome, we call it pre-syncope, and what we think happens is people's heart rate can slow down, and there's reasons for it to slow down that are physiologic, or their blood pressure can drop, and there's reasons for that. And because the heart rate's slowing down or the blood pressure's dropping, suddenly the brain is not getting enough oxygen, and you start to gray out, and you either sit down or you fall down. And what you're talking about, we call concussive syncope, and that's a little bit different thing. It's related to trauma, head injury, and it really doesn't fall into the category of dizziness. It's an important problem, but it's not the same.
But the idea of what the patient is observing through their eyes, is that a similar? Or
Exactly.
It is very similar. Okay.
Exactly.
Okay. So what is causing this type of dizziness then?
So with the patients that are starting to black out, in younger people, it's different than in older people. And in younger people, it's often something we call a vagal response, which is something slows down their heart. Now, that can be a fear reaction. It can be related to nausea or pain or not feeling well. And there's this giant nerve that goes through your body called the vagus nerve, and it's connected not only to your stomach and your intestines, but it's also connected to your heart. So if you have pain or you have stomach problems or you're throwing up or you have the flu, that same nerve can slow your heart rate down to 20. And at about 20, you either need to sit down or fall down. Now that's kind of a normal thing. It's not a normal feeling for sure, but it's not really a disease. And that's something that occurs in younger people. It occurs in a lot of them. It's very frightening. And the most important thing is for them to sit down, really lie down with their knees up and wait for it to pass, and it passes. Sometimes they get very sweaty. Sometimes they get a little bit nauseous, but it passes. And there isn't a lot the young person needs to do about that. It's just something that happens. Now, it's not wrong to get an appointment and check with your doctor. That's always the right thing to do. The thing about this vagal response is it's you don't have it once. Usually if you have it, you're probably going to have it again, at least during the younger years. Now, the same feeling in somebody over 60, we think of differently. We don't think of it as a normal response. We get concerned about heart disease, and in particular if those symptoms are associated with chest pain, shortness of breath, anything that would be construed as cardiovascular, then we think it's a different problem and they probably need emergency care. So it depends on the age with this blacking out thing. And I think I kind of draw the line at around 50 or 60. I treat those patients differently.
And it's not a guarantee that you have a problem if you're 50 or 60 and you have this. It's just simply more concerning to you than if it was a younger patient?
Exactly.
Okay.
Absolutely.
Did you say the cause could be anxiety or fear or?
Well, there is a fourth cause, a fourth kind of dizziness, and we call it psychogenic dizziness. And that's not that people or patients are crazy. It's that the signals to their brain start to be a little bit confusing to them, and so they have anxiety about something, maybe about claustrophobia, or maybe about being in public, maybe about giving a speech. But that anxiety then can cause them to have a dizzy feeling, an anxious feeling, and that's really something we refer to as panic disorder. And panic disorder can be very disabling. It's very, very common, and it's very, very treatable. And it's not dangerous. People that have panic disorder don't die, and but their lives and quality of life can be really disrupted until that's sort of established. And psychogenic dizziness is common, very common.
And with psychogenic dizziness, are you seeing that more in younger or older people?
You can see it in both, actually, and you can actually see it in somebody who has another kind of dizziness. Not to get too complex, but you could have vertigo that makes you anxious. Because you're anxious, then you start getting kind of dizzy all the time, and you not only have vertigo, but you have psychogenic dizziness, and sometimes that can be challenging. But you would see it in both age groups. The treatment in both age groups would be about the same, and it's very treatable.
Would the treatment have anything to do with trying to determine what's causing the anxiety or the trigger and then focus on that, or can you bring a drug into the equation?
Well, always go to the problem. Don't treat the symptoms, treat the problem. And so if somebody has panic anxiety disorder, that's what you treat, not the dizziness. Sometimes you have to treat both to really get the patient back on their feet, but almost always you can just treat the anxiety or even depression. Depression can make people dizzy, and you can treat that, and lo and behold, the dizziness gets better. So always go to the problem and not the symptom.
Jumping back to the idea of kind of your world coming in and keep blacking out sort of a feeling, when someone gives blood, sometimes they pass out. Does that have anything to do with dizziness, or is that a completely different sort of a...
That's the thing with the vagal nerve.
Okay, so that is part of what we're talking about.
That is exactly what we're talking about. And vagal responses are very powerful. In the hospital setting or in the clinic setting, you pull out a needle and you say, we're just going to draw some blood, and boom, they're down.
That just seems so strange.
They're
that
down.
Your brain can look at something that hasn't even touched you yet, and all of a sudden your body completely shuts down.
Very common. Wow. And it's, it's not clear to me that I understand the evolutionary aspect of a vagal response. I mean, clearly, if your heart rate is slow, for you to lay down with your knees up is a survival thing, but why your heart rate would slow down to begin with doesn't exactly make sense to me.
Because if I'm thinking fight or flight, that's
fast heart rate.
That's not
right?
helping me escape a predator.
Right. So and if you pass out, that's not helping you escape a predator.
No,
right?
Not at all.
So the evolutionary advantage, I don't really understand, but vagal responses are very, very common.
What about this one? I've been sitting in an easy chair doing a television binge for 2 hours, and all of a sudden the phone rings and it's on the kitchen counter, and I jump up to go get my phone, and all of a sudden it feels like I'm about to pass out. Would that be within this realm? Or?
Yes.
Okay.
Very common. And that's what we call, it's got a long medical name, it's called orthostatic hypotension, but what that means is your arteries and your blood vessels have a certain tone, like muscle tone, and they squeeze, and they squeeze the right amount to keep your blood volume right and to keep that from happening. Well, people that sit and are not very mobile lose some of that tone. And this is very common, particularly in our older patients, that they can have mobility challenges and not be able to get up a lot. But when they do get up, all the blood rushes to their legs. They feel like they're going out. They sit back down. Then they call me and say, I'm really dizzy. And that is not a vagal response, but it's the idea of your blood pressure going down. Very common. We try to encourage them to move more. We try to encourage them to stay hydrated, drink more fluids. But even so, it can still be challenging.
Could that still happen in a very healthy, active person who's young and jumps up real quickly, and they could still have that, or would that be unlikely?
No, that can happen. It's less common because your blood vessels are much more elastic, much more better toned, much more responsive. But let's say a scenario where somebody has had a stomach flu and they've been throwing up for several days, they're dehydrated, they haven't been able to keep a lot down. Absolutely. That can be an 18-year-old, 16-year-old, 20-year-old, absolutely. And they stand up and they go, uh-oh. That's not uncommon.
Okay. What about disequilibrium? How does that work?
Disequilibrium, this is such a common thing in our older patients. In order for you to stay balanced, there's all this stuff that has to work right. There's your vision, your hearing, you have balance centers in your middle ears, you have a cerebellum in the back of your brain, you have nerves that tell your brain where your joints are and how bent they are. And all those things have to work really right. Well, as we age, some of those things don't work right. Sometimes it's vision, sometimes it's hearing, and it's usually all of those, not 100%, but to some extent. And so what happens is that patient's brain just can't figure out whether they're really balanced or not balanced. And so that becomes frightening and it becomes dangerous. That's how our patients break hips and elbows and arms. And so there's lots of things patients can do about that. They can make sure their vision is corrected by seeing the eye doctor. They can make sure their hearing is optimal by seeing their regular doctor and making sure their ears aren't plugged. But one of the things we teach them to do is to give their brain more information. So a patient that doesn't feel balanced, if you tell your brain more about where you are, like putting a hand on a table or on a friend, suddenly your brain goes, oh, I know where I am now. Well, you can do the same thing with a cane. And it is such a great thing for some of our older patients to do. So the cane is not to put weight on it or to protect a joint or to help with pain. The cane is to tell you where your brain, where you are. So the minute you put the cane in your hand and you touch the ground, your brain says, oh, I know where I am now. And your disequilibrium improves dramatically. The problem is the stigma of the cane.
Right.
And getting the patients to accept it. So you never call it a cane because that's a really bad thing. You have to call it a walking stick or some other euphemism.
A trekking pole.
Yes, exactly. A Swiss trekking pole.
Okay.
But it's really remarkable. Sometime stand up, spread your feet out about 6-8 inches and close your eyes. And kind of get a sense of where you feel balanced and how it is. And then take a cane and touch the ground with your eyes closed and feel how much more balanced you are. And it's not the 3 points, it's not weight, it's more information up here.
That's fascinating.
It works. It absolutely works. I'm looking forward to it. I want to use one.
You're ready to have your Swiss trekking pole?
I'm in.
Okay.
We should talk about vertigo.
Before we get there, you mentioned that all of these senses degrade as we get older and stop working as well, and that kind of leads to this disequilibrium.
That's right.
My question is, can our brain adapt to this information which isn't as good as it used to be and kind of make a correction and look at things differently and bring us back to equilibrium?
Yes.
That's cool.
That's a great question. So our colleagues in physical therapy have programs that specifically work with balance and work with retraining your brain to understand whether you're balanced or not. Now that's new, at least as far as I can recall. 10 to 15 years ago, if you sent somebody to a physical therapist for balance, they would say, what's that got to do with the arms and the legs? And now they're very good at this. It's covered by insurance, and it starts out very friendly, and it gets challenging, but the results are phenomenal. I mean, the patients that go and then they continue to do these balance exercises at home, is a great resource.
So that's worth looking into as a way to cope with this.
Your brain is an amazing thing at how much it can adapt and relearn. And that's true in vertigo, but it's true in any dizziness. Your brain will say, wait a minute, there's another point, a cane on the floor, or wait a minute, I'm learning that I'm balanced even though I didn't used to think I was, or wait a minute, this isn't as scary as I thought it was. Okay. And it can be absolutely retrained.
Now, what is vertigo? And is it the most common of these
It
issues?
is.
It is. Okay, so what is vertigo?
So vertigo is a symptom that there are several different causes of, but there's some that are very common. And vertigo, basically, you have two balance centers just inside your ears, in what we call the middle ear. And those balance centers are very sophisticated sensors. They're tubes with fluid in them, and the movement of the fluid tells you whether you're moving or not moving. And with vertigo, those balance centers become affected, and because in a negative way. And because they become affected, suddenly your brain says, "I'm moving," whereas the rest of your body says, "No, you're not." And so vertigo is this spinning movement sensation when you're not moving. It almost exclusively is triggered by head movement. So people that have vertigo, when they suddenly turn their head, and we could talk about examples of that, everything starts moving, they have to sit down or fall down. And it's this very distinct movement sensation. It's a super uncomfortable feeling.
Does it make you feel kind of sick to your stomach?
Absolutely.
Okay.
It's frightening, and it's very uncomfortable. It's very short-lived. Most vertigo, well, this isn't exactly true, but the vertigo we're going to talk about will only last a minute, maybe 2 minutes. But if you think about being uncomfortable or being afraid, a minute is a long time.
Oh, it could feel like an eternity.
Right, exactly.
If you close your eyes, do you still feel like you're spinning even though you're not seeing the world around you?
Yes.
So you can't escape it?
You cannot. You're still moving. You're still spinning because these canals are telling your brain you're moving. Now, there are different kinds of vertigo. Vertigo can be caused by a stroke. And in our older patients, we worry about that. But it's never vertigo by itself in a stroke situation. There's almost always something else. Difficulty speaking, difficulty with double vision, maybe a hand or a foot that you suddenly can't feel. So if it's pure vertigo, it's very unlikely to be a stroke. And if it's vertigo plus something else, then we get concerned.
Okay. Is there anything that you can do as a young person to try to not get yourself to where you would have vertigo, or is it just being healthy in general that would limit your susceptibility to it?
So the most common kind of vertigo is called positional vertigo. And that is a problem not so much with younger people. It's a problem you might see in your 40s, more common in the 60s. And there's a reason for that, Joel. The reason is these really sophisticated canals in your middle ears. They have these little hairs that wave. And the waving is connected to nerves, and that tells your brain whether you're moving or not. If you move, they move, right? So what happens is we age. There are little pieces of calcium that get into those canals. Debris would be another name for it. But suddenly you have this little piece of calcium in this hair, and the calcium hits the hair, and the brain says, "We're moving," and you're not moving. And those are called cannuloliths. But there are these little pieces of debris that get into the canals. Now, the good news is that can be treated, and it's not even all that difficult to treat. But it's generally related to kind of an aging thing. The bad news is it can be recurrent. That little, let's say you do the treatment and you're able to get the calcium out of the canal, it can come back. And the recurrence rate, it's on the order of 30%. But the worst part about vertigo is when you have it and you don't know what it is and you don't know what to do about it. And, you're home or you're on a vacation or whatever and you're frightened. So the recurrences, the patient goes, I know what this is. This is the vertigo Dr. Smart told me about, and this is what I do about it, and everything's okay, and I'm not going to die.
What do you do the first time if they hear this show? What should you do?
Well, the first time is to make sure that's what you have. Again, there are other causes. Sometimes migraine headaches can cause vertigo. That's a different problem. Sometimes head injuries can cause vertigo. That's a different problem. Concussions. But the first thing is to make sure what you have, what we're talking about. And positional vertigo, in my practice, the patients really seem to notice this more getting out of bed in the morning. I would say like 80% of people, that's what they say. This happens when I try to get out of bed in the morning. So the deal is they're sleeping, they're supine, and suddenly they try to sit up or move their head and they go, whoa. So if that's the scenario and there isn't anything else going on, then that's probably what you have. Never hurts to call the doctor, to make an appointment, to make sure there are other causes, but that's probably what you have. And that's called BPV, benign positional vertigo. So the most important thing you can do is lay back down in bed. And actually, it's gone within a minute. It doesn't last. Now, you could try to get up a second time, and it could come back, or maybe not. But it's usually not just that one time. It's usually a problem that'll recur over the next 2 or 3 or 7 days. And so then you have this positional vertigo, and your question is, what do I do about that? There are things you can do about it.
And Randy, you only have 2 minutes, just so you know.
There are exercises. They're called vestibular exercises. They're on the internet. Sometimes you would search it as BPPV or BPV. There are exercises that involve rotating the head, going from one position to another, and they're very effective. The other thing you could do is call your physical therapist. You don't need a referral to go to a physical therapist anymore. This is new. You could call your physical therapist, say, I have vertigo, could you please treat it? And they can. They can do certain head maneuvers and head positions that actually rotate that little piece of calcium out of the canal. And within a very short period of time, you go, it's gone. I'm back. I feel great. I can hike again, or I can go out to dinner, or whatever it is. I can go to work. So there are very good treatments for it. If you tough it out on your own, it's going to be a long week. Now, you can do it. There are over-the-counter medicines that can help. One's called meclizine. One's called Benadryl. But probably to talk to your doctor.
All right, that's all the time we have. Thank you for briefing us on all these dizziness symptoms, and we'll see you for the next segment.
Thank you so much, Joel.
And thank you for joining us on this edition of Inside View. Hope you join us next time.